Pregnancy and lactation. Objectives. At the end of the chapter, the students should be able to identify the nutritional requirements for pregnant and lactating mothers and plan a whole day menu considering these nutritional requirements. Pregnancy. Pregnancy or gestation is a period when the fertilized ovum implants itself in the uterus, undergoes differentiation, and grows until it can support extrauterine life. Human pregnancy lasts for a period of 266 to 280 days, or 37 to 40 weeks. It consists of three trimesters, first, second, and third trimesters, which correspond to the three main phases: implantation, organogenesis, and growth. This is to ensure optimum nutrition before, during, and after pregnancy and during lactation, and to provide adequate nutrition to meet increased maternal and fetal nutrients demands. Nutrition in pregnancy. Calorie allowances. During the course of pregnancy, the total energy cost of surge plus maintenance or additional work for maternal heart and uterus and a steady rise in basal metabolism amounts to approximately 80,000 kilocalorie. The energy cost of pregnancy then is about 300 kilocalorie per day. The energy intake should be 36 kilocalorie per kilogram of pregnant weight per day. Weight gain. The weight of the blood volume and the enlargement of the reproductive organs are fairly constant. If the weight gain is less than the weight of the maternal components in pregnancy, the growth of the fetus calls on the reserve of the mother. Although weight gain varies, it is generally agreed that the normal curve of weight gain is sigmoid in shape. A small weight gain is observed during the first trimester. A more rapid weight gain happens in the second trimester, and a slower weight gain is recorded during the third trimester. An average weight gain during pregnancy is 24 pounds, which is commensurate with a better than average course and outcome of pregnancy. A gain of 1.5 to 3.0 pounds during the first trimester and a gain of 0.8 pounds per week during the remainder of the pregnancy should be the guideline. The pattern of weight gain is more important than the total amount gained. A sudden gain in weight after the 20th week of pregnancy may indicate water retention and the possible onset of preeclampsia. This table shows the components of maternal weight gain. Maternal weight. First, underweight. Has high risk of having low birth weight infants. Has higher rates of preterm deaths and infant deaths. Second, overweight and obese. Has higher risk of complications like hypertension, gestational diabetes, and postpartum infections. Complications of labor and delivery. Increased likelihood of a difficult labor and delivery, birth trauma, and cesarean sections for large babies. Doubled risk of neural tube defects. This table shows the recommended weight gain during pregnancy. Protein allowances. The additional allowance of protein during pregnancy takes into account the increased nitrogen content of the fetus and its membranes, maternal tissues, and the added protection of the mother against complications. It has been estimated that about 950 grams are deposited during the last 6 months of gestation. Reasons for the additional protein. First, to provide for the storage of nitrogen. Second, to protect the mother against many of the complications of pregnancy. Third, for the growth of the woman's uterus, placenta, and associated tissues. Fourth, to meet the needs for the fetal growth and repair. Fifth, for the growth of the mammary tissues. Sixth, for the hormonal preparation for lactations. Nutritional needs during pregnancy include: first, the normal requirements of the mother. Second, those of the developing fetus, including also the uterus and placenta. Third, building up reserves in preparation for labor and lactation. Calcium allowances. Some calcium and phosphorus deposition takes place early in pregnancy, but the amounts are small. During the latter half of pregnancy, the intake and retention of calcium is considerably increased. It has been shown that the calcium and phosphorus retained in the fetus during the last 2 months of pregnancy are 65% and 64%, respectively, of the total body content of the full term fetus. Iron allowances. At least 700 to 1000 mg of iron must be absorbed and utilized by the mother throughout her pregnancy. Of this total, about 240 mg is spared by the cessation of the menstrual flow. The remainder must be made available from the diet. The rate of absorption is increased, therefore, in the third trimester when the needs of the fetus are the highest. Iodine allowances. Iodine is especially important during pregnancy to meet the needs for fetal development. An inadequate intake of iodine may result in greater in the mother or the child. The increased need for iodine can be met by the regular use of iodized salt in food. Vitamin allowances. Thiamine and niacin allowances are increased in proportion to the calorie increase, while riboflavin allowances are increased according to the higher protein level. The need for vitamin D is increased during pregnancy to make easier the utilization of greater amounts of calcium and phosphorus. Ascorbic acid, vital in tissue structure, is required in considerably increased amounts. Food allowances. First, 1 ounce or 30 grams of meat or its equivalent and an extra pint of meal to the normal diet. Second, daily consumption of whole grain cereals, enriched bread, rice, leafy green and yellow vegetables, and fresh and dried fruits. Third, liver at least once a week. Fourth, egg in the daily diet. Fifth, fortified milk with vitamin D or fish liver oil. Sixth, 6 to 8 glasses of water daily. Complications of pregnancy and possible dietary modifications. Nausea, vomiting, improper body weight, and toxemia are among the many conditions that complicate the normal course of pregnancy. They influence the intake, digestion, absorption, and utilization of essential nutrients. They become even more serious when gestation occurs during adolescence. Rapid weight gain or loss. The popular concept of eating for two is not valid among well-nourished mothers. It may lead to overweight with consequent toxemia, difficulties of labor, and birth of large, sickly babies. Excessive weight gain during pregnancy is defined as an increase of 3 kilograms or more per month in the second and third trimesters. A sudden increase in weight after about the 20th week of gestation is a cause for suspecting that water is being retained at an inordinate rate and should be regarded as a warning sign of an impending eclampsia. Toxemia. Rapid weight gain, edema, high blood pressure, excretion of albumin in the urine, and convulsions are clinical manifestations of toxemia. Its classifications are as follows. First, acute toxemia of pregnancy. It onset after the 24th week. Preeclampsia, hypertension with proteinuria and or edema. Eclampsia, convulsions or coma, usually both when associated with hypertension, proteinuria, and edema. Second, chronic hypertensive vascular disease, without superimposed acute toxemia and with superimposed acute toxemia. Anemia. The classic macrocytic anemia of pregnancy represents a combined deficiency of iron and folic acid. It produces anemia in babies and increases the chance of premature birth. Once anemia is established, it is difficult to overcome the condition even by raising the level of iron in the diet, although its absorption can be enhanced by the inclusion of ascorbic acid-rich foods in the same meal containing rich sources of iron. Diabetes. A pregnant woman with diabetes is more prone to develop preeclampsia, pyelonephritis, and polyhydramnios, an excess of amniotic fluid, and her baby has a higher risk of dying in utero or at birth. Rigid control of maternal blood glucose concentration is considered vital for a good prognosis of the fetus. Constipation. Pressure exerted by the developing fetus on the digestive tract. Lack of exercise and insufficient bulk in the diet cause constipation. which, if chronic or habitual, gives rise to headaches and much discomfort. Lots of fresh fruits, vegetables, fluid, and regular exercise can correct this disorder. Socioeconomic and cultural factors. Low income groups tend to have big families. One reason for the decrease in kind and amount of food available to the pregnant mother. Unusual eating habits such as frequent snacks rich in carbohydrates, irregular meals, special cravings such as raw white rice and green mangoes, and odd eating habits like chewing cigarettes, chicken manure, and sort of pots deprive the mother of wholesome foods. Alcohol, caffeine, nicotine. Smoking during pregnancy lowers the mean birth weight and increases the risk of perinatal mortality. Smoking seems to affect the conversion of dietary calories into weight gain. When segments of umbilical cord from mothers who smoke were studied, large areas of swollen and irregular endothelial cells were found. It is postulated that smoking increases the mother's level of carboxyhemoglobin and nicotine, causing a decrease in the oxygenation of the fetus. Increasing the food intake of pregnant smokers can compensate for some of the effects of smoking. Mother's age and associated health concerns and risks. Pregnancy in adolescents. 1 out of 20. It has an iron deficiency anemia, prolonged labor, and higher rates of stillbirths, preterm births, and lower birth weight infants. Pregnancy in older women. It has an hypertension and diabetes. It has an higher rates of premature birth and low birth weight. It has birth defects and fetal death. Lactation. The preparation for assuring an adequate supply of good quality breast milk must begin at the onset of pregnancy. Most of the dietary essentials are increased over and above the requirements during pregnancy to meet the demands of milk production, namely calories, proteins, calcium, vitamin A, thiamine, riboflavin, niacin, and ascorbic acid. Nutrition in lactation. Calorie allowances. The food requirements are not uniform during the entire period of lactation. Nevertheless, they depend on the demands of the infant. It is generally suggested that the extra food calories should be about twice those secreted in the milk of approximately 700 to 1,500 calories of food for 500 to 1,000 ml of the milk. The ENRI recommends an increase by 1,000 calories above the normal requirement for an average production of 850 ml of milk with an energy value of about 600 calories. Human milk is approximately 0.70 calories per ml or approximately 20 calories per ounce, and it contains 1.2 grams protein per 100 ml. Protein allowances. Lactation makes large demands on the human stores. The food intake of a nursing mother must contain sufficient proteins to supply both the maternal needs and the essential amino acids to be transferred through her breast for the baby's growth. Additional protein in the diet tends to increase the yield of breast milk, while a decrease of protein lowers the amount of milk secreted. If the amount of protein in the mother's diet does not meet the body maintenance needs, the necessary protein content of the milk secreted, a loss of maternal body tissues will result. The average protein allowance for the lactating mother is an additional 20.2 gram protein to her normal requirement. In such a case, a 20-gram factor may be used. Calcium, phosphorus, and vitamin D allowances. During lactation, the demand for calcium and phosphorus is increased above the requirement of the pregnant woman. The calcium allowance is 1.0 gram daily for good milk production. If the protein requirement and other essentials of the diet are fulfilled, the increased need for phosphorus will be met. The vitamin D requirement of 400 IU remains the same as during pregnancy. Iron allowances. Some lactating women tend to be anemic unless the iron allowance in the diet is increased to the same level as that during pregnancy. During lactation, the loss of iron which is considered on an annual basis is probably similar to that which is lost in the menstrual flow. The baby is born with a relatively large reserve of iron. Since milk is not a good source of iron, a good allowance of iron in the mother's diet during lactation does not convey additional iron to the infant. Nevertheless, iron-rich foods are essential for the mother's own health, while supplements are included early in the infant's diet. Vitamin allowances. There is an increased demand for vitamin A, niacin, riboflavin, thiamine, and ascorbic acid above the requirements of pregnancy during lactation. Foods need in lactation. Nutritional requirements. The nutritional requirements in lactation are greater than in pregnancy to ensure enough supply of milk for the baby. Calories. An additional of 1000 calories above the normal allowance is needed. An approximate amount of 120 calories is required to produce 100 ml of milk. Thus, the daily production of 850 ml of milk will require an additional 1000 calories in the diet. Energy-giving foods are good sources of calories. Protein. An additional 20 grams to the normal allowance is needed to compensate for the protein lost in milk. The conversion of food into milk protein is only about 50% efficient, thus 2 grams of food protein is required to produce 1 grams of milk protein. Sources are milk, eggs, animal proteins, and legumes. Calcium and phosphorus. An increase of 0.5 mg to the normal allowance is needed to prevent severe depletion of maternal calcium reserves since this is used for milk production. Sources are milk and milk products, eggs, and etc. Iron. An additional intake is recommended for blood lost in parturition for milk iron and basal losses. Vitamin A. An additional 20,000 IU to the normal allowance is needed to provide the amount of vitamin A secreted in milk. Sources are green, leafy, and yellow vegetables, milk, eggs, and etc. Vitamin B1. An additional allowance is needed for thiamine secreted in milk. A mother whose diet is very low in thiamine may secrete a toxic substance called glyoxylin, which accumulates in thiamine deficiency. Its presence with the low thiamine content in milk is associated with infantile beriberi. The sources of vitamin B1 include unpolished rice, legumes, vegetables, milk, and etc. Riboflavin, vitamin C, etc. An additional allowance is needed for milk secretion. Fluids. An intake of 8 glasses or more is recommended to increase milk production. This is a dietary allowance for lactating mothers. Breastfeeding misconceptions. First, a mother is sick with tuberculosis cannot breastfeed. Second, breast milk is not good if the mother has stayed long under the sun. Third, a mother cannot breastfeed during pregnancy. Fourth, a mother cannot breastfeed with only one breast if the other breast is painful. Fifth, a mother cannot breastfeed if she has a cold, flu, or diarrhea. Last, breast milk is not good if the mother has been caught in a sudden shower. Advantages of breastfeeding. First, breast milk provides passive antibody transfer to the newborn. It simply means local immunity of the baby to some children's diseases. Second, breast milk is higher in lactose than cow's milk. The lactic acid converted from lactose limits the growth of disease-producing germs in the GI tract. Third, breastfed babies have no difficulty with the regulation of calcium phosphorus level than those who are bottle-fed. Cow's milk contains high level of phosphorus which lowers the calcium level due to the inverse relationship of these two minerals. The decreased calcium level in an infant can cause tetany or muscular spasm. Fourth, bottle feeding affects the dental arch. The tongue thrusting in bottle feeding may cause malformations of the dental arch. Fifth, cow's milk protein causes allergy. Sixth, breastfeeding also benefits the mothers. Less incidence of breast cancer in women who breastfeed. Less incidence of thrombophlebitis or inflammation of a vein with formation of blood clot. and rapid return of the original size of the uterus. Factors affecting milk secretion. First, diet. The volume of milk secreted is affected by the diet, but the protein and calcium compositions are not. Meat and vegetable soups, such as tahong, tulia, alungay. Milk and fruit juices have been referred to as galactagogues. Water should not be drunk beyond the level of natural thirst because it suppresses milk secretion through its action on the pituitary hormone that regulates milk production. Second, nutritional state of mothers. Energy yielding constituents of human milk are maintained at the expense of the maternal stores, while the water soluble vitamins and vitamin A are low in poorly nourished mothers. Sufficient nutrient reserves in the mother's tissue before conception and during pregnancy influence milk secretion. Malnutrition and illness such as cardiac and kidney diseases, anemia, beriberi, tuberculosis, and infections can lessen the quality and quantity of milk flow. Emotional and physical states. Attitude affects milk secretion. When the mother worries or frets about the sufficiency of her milk, about her breast contour, and about being tied down in her home, the flow of milk stops. A relaxed temperament, pleasant surroundings, lots of rest, and good sleep enhance milk secretion. Fourth, suckling. The presence of the baby and suckling immediately after delivery stimulate the milk producing glands. As the baby feeds for longer periods of time, the supply of milk increases in proportion to the body's demands. Increased frequency of nursing is positively associated with infant weight and lactation period. Fifth, use of contraceptives and drugs. Women who use contraceptives like pills while breastfeeding depress milk flow, and the insufficiency of milk triggers the cessation of lactation. Most drugs, including alcohol and nicotine from smoking, reach the milk sometimes in physiologically large doses, thus affecting the quality of milk secreted.